the first start of my PhD, my focus was on investigating monocytes and macrophages. These are immune cells that play an important role in giant cell arthritis, as we can see them in the vascular wall where the inflammation is. And during my PhD, I also connected more with the clinical side of the research, and there were some questions that patients had and that are relevant for their disease. And then I used my knowledge from the side of the monocytes and the macrophages to tackle these questions that these patients had for a more clinical side of the research. So I started with products that these monocytes and macrophages make, and they are in the vascular wall, and that they are very activated, and that's why actually you have this disease. And they're the most common cell in that location. So you have a lot of cells, and they produce all these products, and you can find them back actually in the blood, in the serum. So we have a large collection of serum samples from our GCA patients before their treatment and during their treatment. And in these samples, we investigated levels of these markers for monocytes and macrophages. And with these markers, we have found we can answer important clinical questions to help the diagnosis, but also to help the monitoring of these patients and to predict whether some patients will respond well and other patients don't. So one of the studies we did was to improve the diagnosis of giant cell arthritis, because what we see is that patients come in with complaints that could be giant cell arthritis, but it could also be other mimicking conditions. In many cases, these could be infections. But what we also see is that a lot of these giant cell arthritis patients also have overlapping disease called polymyalgia rheumatica. And it's sometimes really hard to distinguish these different groups of patients. And that could actually be really important, because these diseases require, of course, different types of treatment. Giant cell arthritis patients require a lot of steroids, and this is not the case for patients with infections. And PMR patients are in between. So that's why we looked at some of these markers from monocytes and macrophages to see if they could help us with the distinction between GCA and PMR, or GCA and infections. And my study here in Groningen found actually that one of these markers, angiopoietin-2, that's produced by, among other cells, by macrophages, that if their levels are high in patients that have symptoms of PMR, but if the levels are high, then there's a very large chance that they also have giant cell arthritis. So that could be really useful for distinguishing these two patient populations that might appear to the doctor as the same type of patient. So that could be a very useful tool in the future to help selecting patients for further diagnostic tools. So you could pick patients that would need a biopsy or imaging. And so when we got these results, we were very happy with it. But of course, it's only one study, and that doesn't prove that much. So what I did next was, with the help of a small grant, I could go to Denmark to investigate these same biomarkers in their cohort, because they also have a nice cohort of GCA and PMR patients. And it was really nice to find the same marker there as well as here, that the results were similar, and that also angiopoietin-2 could be useful in finding GCA among PMR patients. So I was really happy to find that result in both cohorts. Furthermore, another important question that we had was whether we could predict for some patients whether their response during treatment was good or bad. And in some cases, patients have relapses very often. And other patients that perform really well on steroids and could taper their steroids within a year or a bit more until they don't need any more glucocorticoids. That's the steroids, sorry. So the question is, could we predict that at baseline? So if we see a patient, can we say, well, this is a type of patient that responds well and another type of patient that doesn't respond well? And we also use biomarkers for that. And for giant cell arthritis, the best biomarker to predict a good response was another product by macrophages called VEGF. And it's actually part of the same sphere of biomarkers as angiopoietin-2. So there appears to be something going on in this process. that can predict the steroid use and can also help us with the diagnosis. So we hope to also confirm that in the Danish cohort, but that will take a bit longer.